In this episode of the Nurse Practitioner Podcast, Dr. Kerry A. Milner and Dr. Fineout-Overholt explore strategies and best practices for effectively implementing your DNP project, overcoming challenges, and sustaining momentum. Part 3. Thanks so much for joining us today.
It's our privilege to join you today.
Yep. Thank you. Glad to be here. Hey, Ellen.
Thank you.
So first, in regards to implementation, what key activities should you prioritize during the implementation phase to keep your project aligned with its goals and to adapt to challenges?
Great question. I'm going to start first with some general guidance around the implementation phase, and it is preceded by a well-crafted implementation plan developed during the planning phase. This lays the foundation for success. It should include specific strategies to address potential barriers identified earlier. These can be things such as staff resistance, resource limitation, or workflow disruptions. Also, during the implementation phase, you should prioritize regular monitoring of progress, frequent stakeholder engagement, and maintaining flexibility to address unexpected challenges. And then built into your implementation plan that you will now use in the implementation phase is some project management tools. And some examples of that would be a Gantt chart for tracking your timeline or milestones so that you can keep everybody on track. It's a visual thing, so you could see it. There's also something called a Kanban board. This visually shows the workflow. It identifies bottlenecks. It helps you maintain progress, so that could be used too. Consistent data collection and analysis will help assess whether the outcomes align with the objectives or your project goals. And then support your team with ongoing training or additional resources as needed. In the context of academia, DNP students should check in with their faculty advisor regularly during the implementation phase to provide updates on progress, discuss any challenges, and ensure that the project remains aligned with its goals. This would be similar for clinical practice. They would do it with their team and their key stakeholders. And the frequency of the check-ins should be based on project needs and academia advisor expectations. So for the students I advise, I initially want to hear from them during the first week in case there's any challenges that they need my support with. Then it can be weekly. Then if things are going well, we can go to bi-weekly and then monthly. If they're having a challenging time, we're going to meet more frequently so that I can support them as the faculty advisor. And that, I also encourage that they work with the clinical team. So what is this for academia? What does this look like? It can be in the form of a quick email or a virtual meeting if the project's not going as planned. I want DNP students out there that are listening to this podcast to hear that it's not okay to have no contact with your faculty advisor during implementation, because that person is really a source of good support for you if you're having challenges, and they can give you, great advice. So I want to follow this up just with a quick example because I think that might help with people understand. I think I've in prior podcasts talked about the blood culture contamination project. And so during the implementation phase, that team prioritized weekly audits of blood culture collection practices. The ED staff participated in weekly huddles to reinforce training, share feedback, and address concerns. When the staff expressed resistance due to high patient volumes, the team adjusted workflows by assigning specific roles like designated blood culture champions to oversee proper technique. And then the project management tool they used was the Gantt chart. So that showed the milestones, when the training was completed, and the contamination rates when they did the audits. And lastly, they laminated cards that had on-the-spot coaching so that there could be immediate assistance to staff to follow best practices for when you would draw those blood cultures.
Thanks so much for sharing that important information. Next, what are the best practices for documenting and reporting deviations from the project plan?
Another great question. So some general guidance around documenting and reporting deviations from project plans. So best practices start with, again, I'm going to bore you with well-designed implementation plan. Planning is everything. And you plan for what the possible challenges or potential barriers may be. And that you also include strategies for how you might respond to these. So if you do have a deviation, it should be documented and managed. So how can you do this? Well, create a deviation log to record and categorize the deviations as minor or major, and that would be based on their impact on the project. Communicate the deviations transparently in real time to your stakeholders, your clinical mentor, the faculty project advisor. The focus should be on root causes of these deviations and any corrective actions that you need to do. Use standardized formats for reporting. This could be spreadsheets that you've structured the columns, or another great thing is the dashboards. And your mindset should be treating these deviations as opportunities to refine the processes and to improve outcomes. So just to share a quick example using the blood culture contamination project. In that project, a notable deviation occurred when contamination rate spiked over a week period. Really, it was a weekend, and it was due to a sterile kit shortage, not being able to quickly get those. So the team documented the date, the shift, and the contributing factors. Those were like high patient volume and lack of supplies. The deviation was categorized as major because it reflected a supply chain issue. And then this information was shared in the huddles. The ED nurse manager and the project manager, who is the DNP student, communicated this. And then they're using their Gantt chart. They put that restocking sterile supplies was stuck in progress. So people could visually see that if they wanted to. And then, the lesson learned was increasing the stock of sterile kits and adjusting the restocking schedule to prevent future shortages.
Documenting consistently makes it easier to spot and address any deviations. Thanks again for sharing. How often should you communicate with your DNP project faculty advisor during the implementation phase to ensure alignment and address challenges effectively?
So for this question, I spoke about this at the beginning of this because, my lens is I'm both a nurse practitioner, but I'm also a full-time professor and overseeing DNP projects. So I like to see my students and talk to them often. So again, the general guidance is that you definitely should have on your timeline check-ins with your faculty advisor. And in the clinical setting, this should be, check-ins with your team. And it's, if things are going well, you have to decide, it should be at least weekly because you'd want to look at the data. Things aren't going well, it may have to be sooner than that because you are making decisions, making changes, and then you have to see what the effect of that change is. And you should close the loop on the communication to say how it went. So for this, I like this formalized with the student, but it's based on your style. You can either have it formal or informal. And it should be noted that if there is any significant issues, you should talk to your DNP project advisor right away. And I would think, similarly in the clinical setting, that you would want to talk to your stakeholders if it's a major deviation. So our blood culture contamination example, weekly meetings were held all the time like that. They never changed from that because the team liked that. It was comfortable for them. And when the contamination rates did spike, they met more frequently. They met a few times that week, and then they did the corrective action, and then they made sure to check in probably twice a week after that. Huddles is a good time to do this. And then to give data back on how you're doing on things. That's important because you may want to do that weekly if you have access to a dashboard. That might take a little bit longer time, but those things are important to keep your stakeholders as well as staff engaged in your change if it impacts them. So it's a strategy to keep engagement. So that's something that you might Depending on how quickly they can update your dashboard, because some of the dashboards are in real time. That's a nice thing too. And then just for project management tools, the Gantt chart, you should be updating that if you need to as you go, referring to it, have it up so everybody could see it.
Sounds like frequent check-ins keep everyone aligned and help solve problems quickly.
Yes.
One of the things I thought about, Kerry, as you were speaking, is that your faculty advisor and your clinical mentor are your partners in this work. Sometimes I think DNP students and other students may see that as hierarchical versus a partnership, which is there is expertise to be gained from the clinical mentor and the faculty advisor, along with the student sharing how things are going and all of those things as an accountability piece. It's about also getting information or insights from your faculty advisor and clinical mentors so that you can go, I hadn't thought about that, because DNP students are busy and they might not have seen that lens that they could get from their faculty advisor. So I think the more frequently you can meet with them reasonably with everything that you have going on, the better off you are. But I love the options that you offered of asynchronous, if you will, connections through like a commonly shared Gantt chart or something where they can see what's going on, our dashboard, to see what's going on, but then you get those in person, if you will, or virtual meetings, however your program works, so that you can explain, okay, here's what I'm learning, all of those kinds of wonderful things. So you offered a lot of great options there. Thank you.
Great advice, Ellen.
If engagement and data trends were strong initially but later returned to baseline, what steps can you take to address this shift?
This happens commonly, and students, they deflate. They deflate when this happens, and I think it's common with practice changes. So some general guidance. And I am repeating myself, so a strong implementation plan should include strategies to sustain engagement and monitor trends over time. So if the data trends regress, one of the things top of my list is reassess the stakeholder engagement to identify if there are declines in motivation, or the biggest one is competing priorities, because DNP students often might go into this. I think they learn very quickly that their project isn't the only project that's going on. And so there are competing priorities for other metrics that the setting is trying to meet or exceed, or other things. So they learn that quickly because they'll do their training, they'll have their kickoff meeting, and everybody in the clinical practice will be so excited, and they truly will be on board and ready to do whatever they need to do. And something else could come along that they now have to focus on that. And so then they may drift off from your project. And so you just have to bring them back. So when this does happen, another thing is assess the root causes. Bring out your quality improvement tools for this. So you could bring out a fishbone. You could do the 5 whys. This can give you information to figure out, do I need to adjust the intervention? Meaning, like, do I have to simplify a workflow? Do I have to address a new barrier that popped up that I didn't know about before? Did something happen since I did my implementation plan that's new in the clinical setting that now is a barrier for my project? The other, easy or simpler things are reinforced commitment by celebrating successes. I really like the one of sharing data-driven outcomes. If you're able to share, we've moved our outcome, even if it's just a little bit, and we're headed in the right direction and we're trending in the right direction, very powerful. If you find you're going down, down, down and really struggling, and I think Ellen mentioned this right before this question, you need to pull in your leadership. You need to partner with your clinical mentor. You need to partner with your advisor to help with sustaining accountability, momentum. Those kinds of things can help you. So let me give you an example. In the blood culture contamination project, the data, started out with a trajectory that the contamination rates were going down. Then they spiked, returned to worse than baseline. But later, ultimately, over the 3 months, they improved to where they were benchmarked at. So some of the things that happened along the way, staff were fatigued in the emergency department by the competing priorities. So the project manager re-engaged them, offered refreshment training, reminded them, why are we doing this? Also, it's something you could do if you want to. The staff that were top performers, they were recognized with an Amazon gift card. Can't always do that. Some health systems will, they have you good catch, right? Good catch. And they'll give you, they might give you a coffee gift card or something like that. So it's not something totally out of the realm of things. They did a fishbone. And so the fishbone revealed workflow inefficiencies and inconsistent use of the sterile kits. So they addressed that. Then I haven't mentioned it in my example up till now, but they had a Kanban board. They started using that, and in their to-do column, they put the sessions were prioritized and in less busy shifts, trying to do this stuff. So not doing it in the training sessions or when they're really busy. So think of the unit flow of things too. And then they shared all the data and had open communication all along in the huddles, so that then when it started going back up again, they were able to say, hey, because you worked so hard and you re-engaged, it made a difference. We're doing better. And then the ED leadership, they sent a consistent message of this is an important project. This is important to the organization because we do not want high contamination rates. We've got to get them so that they're at the benchmark or lower.
Thanks for sharing this helpful information, Kerry. We're sure our listeners will find it helpful. How can you effectively compare your project outcomes to its initial goals and objectives?
It's a great question, and actually a question that the content of this is often overlooked by students because they don't make these connections. So I'm so excited for the opportunity to talk about how do you make connections between what you planned in the beginning, where you started, and how you are at the end. Sort of like discharge planning, right? It begins when the person hits the floor, right? Hits the unit, hits the doors of the hospital or wherever it is. So great question. I'd say the first and foremost requirement for effective comparison of baseline to final project outcomes is rigorous data collection and valid measurement of outcomes from the beginning. So when you're describing your clinical problem, you're going to be doing that. You're going to be looking at what is the outcome now. So everything that flows into what describes the outcome at the beginning of the process is where you revisit at the end of the process. Once solid data are collected, it's much easier to demonstrate that the outcome is either meeting the established benchmark or not meeting the established benchmark. And it's much easier to look at the comparison between the beginning, where you were at baseline, and then at the end of the project. There's also not only impact we call them outcomes that show an impact of the project. So what did did you actually get the outcome you thought you were going to get? Reductions in VAP, increased accuracy, if you will, in blood culture collections or decreased contaminations, those kinds of things. But there's also process targets that we look at. And so when you think about evaluation, don't think about only just the impact outcome or the thing that said you made this difference, but think about how did the project work? How was the intervention implementation process? How did it go? Did it go like you thought it would? Kerry talked about this rigorous implementation planning. Well, did your plan go like you thought it would go? So we have things we call process measures, or ways, some people might call them even milestones in performance improvement, to think about, did these things happen like that we said they would, in the timeline we said they would? Did we meet all those milestones? And if we didn't, why not? Those are all kinds of evaluation processes that you're going to be using to determine, did you do what you thought you were going to do? Because that can influence that impact outcome or the outcome that you hoped that you were going to change. Again, it goes back to rigorous data collection and looking back at your recommendation and understanding that the recommendation was to do this. Did we do what we said we would do? And then it looks at, for process in particular, we have a thing called a process map that we encourage all DNP students or anybody who's making a practice change to create a process map for what's currently happening at baseline. What are the processes going on at baseline and getting us to this now outcome we want to see different, that we want to see changed. And then so at the end of your project, you would look at what that map was at the beginning and create a new one to go, what are the current processes now going on after I have done my work? And see, where are the processes changing? Are the ones that I expected to change currently changed? Or is there something new introduced into the process that maybe had nothing to do with your project at all? Which could be all of a sudden the organization decides that we're going to go in this direction. And you went, wait, that might mess up my project. And they're like, well, we got to go this way. So you then have to figure out what happened when that process changed, and did that influence your impact outcome or the thing that you wanted to see change. So those kinds of evaluation strategies are really important, and it's important that you don't forget that there are two ways you're evaluating. One is that outcome you wanted to see changed, which we call an impact outcome, and the other is the processes that you wanted to see get to that outcome. Did they go along the way that you planned them to? And if not, why not? And then starting to think about what difference did that make in how your outcome was achieved.
Thanks so much for sharing that advice, Ellen. Next, what strategies can you use to accurately interpret the data collected during your project?
Oh, such a powerful question. Thank you for asking it. This is always a struggle, I think, for students and perhaps for faculty. How do I put these data forward so that they can be digested by who you're trying to communicate with? Because data that you're sharing about your project aren't just to fulfill an academic requirement, although they do, of course. But you're trying to communicate to those key stakeholders that Kerry was speaking about before. You want them to clearly understand what happened and the difference that it made. And so how you construct these data and how you display them is really critically important. My recommendation, and Kerry can weigh in, my recommendation are that project data are simple data, not sample data, simple, SIMPLE. And therefore the analyses are simple. We often just use absolute differences for the outcome, baseline to end of project. We often do the same thing with any change that we're thinking about. How are we getting to that desired process? Did this process work? Here's the process before, here's the process after. Yes, no. Did the process change like we thought it would? Yes, no. Those are very simple. And how often did it happen? Those are like frequencies. These are very simple analyses. They don't have to be big and complex because we're trying to understand what happened in this context. And so we really would encourage you to use that simplified approach so that you can accurately interpret your data and see it from baseline to end. Sometimes faculty and students wonder about whether or not inferential statistics are to be used, where you're really looking at statistical significance. And are they part of a project evaluation and interpretation of data for either evidence-based practice, evidence-based quality improvement, or quality improvement projects? And the answer is no, they aren't appropriate, and here's why. EBP, QI, and EBQI projects are focused on interpretation only within that setting they were implemented in. They're not generalizable information. Even though they may be published, why would it be good to publish a project? Because if you don't have any other evidence but 10 projects that have been published, and they all agree, and they all use similar processes, and they all evaluate the same outcome, we have now lower level, but a body of evidence to help us think about how should we go forward. These aren't definitive. Our confidence would be definitely cautious about using that evidence, but it does help us to understand. And we can't statistically say they found it by chance, they didn't find it by chance. They found it. That's what matters, is they found it in their context. So those are important things to think about. Remember that interpretation of data is context driven. Meaning, what happened in this project? Did a major change in the healthcare happen? Did a downtime event occur that affected the project? That project may be valuable to understand just because that happened. So there is no expectation that the information that you find, the process, the outcomes, and the trajectory within your project is going to be generalizable to anybody else. And so that's why inferential statistics don't really help us with understanding what happened in the project better. Also, remember that projects are 100% time limited, right? There's only so much time, particularly if you're a DNP student, you have so much time to implement. You want to be reasonable about what you're trying to achieve and how you're going to try to achieve it. So thinking about strategies for evaluation and strategies for analyses, you don't want big, huge, complex, multivariable information. You want simple. So I was just going to give you a couple of examples. Let's say that a DNP student who wants to look at a system, they want to look at a system because they're systems influencers. But they go, okay, I know that PACU here is having a problem with having consents come through with no signature. And that's a bother to me. And so I'm going to think about and ask the clinical question, do all the work, and then now they have their plan for what they're going to do, and they're going to increase communication. They're going to work with interprofessional partnerships. They're going to do all these things. Great. When they look at that, guess what might happen? Now, the DNP is the systems influencer. They want to take it small and make it and then spread. But all of a sudden, the system CNO says, wow, that's a great idea. Let's push it, right? So now the DNP gets an opportunity to partner to go bigger, but the focus is still on that organization, that system, not on another system in another state with other variables, with other influencing factors. It's still on that. So it's still those simple statistics. Does that make sense? Kerry, I'm going to ask you.
Yeah, Ellen, I'll jump in. So in the education, in the coursework of DNP students, Microsoft Excel needs to be taught because that is the software that DNP students can use to come up with simple percentages. They can look at means, even standard deviation. So we call those descriptive statistics, and that's what should be used. And you accurately said that inferential statistics are not appropriate because the purpose of the project is to improve or to address the clinical problem in that setting, in that context. And you would never have the assumptions that you need to for the statistical let me say that again. You would never have the statistical, you wouldn't meet the assumptions for the statistical tests that fall under inferential statistics. So it would be wholly inappropriate. And then I really like how you talked about impact. Impact can be very simple. And so Excel is very simple. You can, put your, I'll use the example of a palliative care trigger tool that was led by a nurse in the ICU. So they would monitor weekly the time it took to the palliative care referral. It lended itself to just do it in days because prior to the start of this, the average, so the mean, and you can use Excel to figure that out, it was 16 days. 16 days to the palliative care referral. So we know that in the ICU, you could be gone to another level of care or you could have died. That's too long. So at the end, they were able to show the impact of decreasing that over 3 months to less than 2 days. So Ellen, and you and I have talked about this. I love plain language because then everybody could understand it and that we don't need to use fancy language, that intervention from the evidence that was implemented in that ICU decreased palliative care referral time from 16 days at baseline to less than 2 days after 3 months.
Perfect.
What are the best methods for displaying data in a clear and impactful way?
It's a great question, too, and it's related, certainly, to what we just talked about. If you have simple data with simple analyses, you have the best methods to display those data are through a table or a graph. And you can pick which kind of graph works best for your data. So it might be a pie graph, it might be a bar graph, or a pie chart, but it's about what data you have. These can be completed in Excel or Google Sheets as well. They'll come up. You can have them easily created in those software platforms. The key for students is to know what their graphs and tables mean and how to explain those. It's great to have tables in your DNP project report, but you need to know what they mean and how to explain those and have that part of your report, because otherwise, when you present the data to the key stakeholders, you need to be able to explain what those mean, and those should just flow right into your report, the explanations and the graphs. Faculty and students don't need to limit the number of tables or graphs they have, because sometimes you need smaller chunks of information for the people to follow what you're doing. Sometimes you have only a couple of them if that's appropriate for your project. So there's no one answer about how many to have, but it's about how do you create a picture, because that's what tables and graphs are for, is to create this snapshot or picture of your work so that people can understand what you did and the impact that you made. So meaningfulness is really key to these tables or graphs for the people that you're trying to speak to understand your project.
So great. I would just like to add, Ellen, that this is, again, something that I know where I am, we can improve on, giving more coursework for how to do this. My little trick is that in a university, if you can find your school of business or college of business people in a health system, your marketing people, perhaps, they can help you with these graphs of, a lot of the graphs have to do with trends over time. The other thing is you can go to YouTube and you can search for how to create something and then follow the steps. What's becoming exciting, but you have to be very careful because you would be putting your data out there. So you have to just figure out what some of these AI softwares can help you to create pictures. But we have not, the thinking hasn't caught up with, what does that mean if you put your data in there? That's for a different podcast. But just want to share that.
Next, how can you present the economic impact of your project, including calculating return on investment?
Thank you for asking that important question. And this is often, again, something that's overlooked by every project change management project because this requires a little bit. If you think about it, the return on investment, or what we call ROI, is a financial gain that's achieved for each dollar invested into this project. So you need to capture that, right? And then what was the outcome of the project, and how is there a difference between those two? And then the ongoing benefit that's going to be from the work that's been done and put into the project. So it's important for students to include cost in their project planning, not only, doing it at the end, but in the planning, because it takes a long time to collect the data on what the project costs. Any potential cost savings, it takes a bit of time to figure out what will that look like. What will the organization support for ongoing measurement of that so that you can continue to see that? And of course, any revenue generation that's associated with the project. Cost savings may include reductions in medical errors, adverse events, hospital readmissions, or length of stay, as well as minimizing wastes, such as fewer unnecessary tests or supplies. And we don't always think about us generating revenue, but you could think about that as increasing reimbursements that are tied to improved quality metrics or enhancing care delivery efficiency, which may enable an organization to serve a larger number of patients so that you get more revenue to come in. There are several estimated project costs that students should consider adding to their way of determining the resources. We, in our AJN series, talk about using a logic model to really look at those resources carefully and what they're tied to as far as initiative that you're doing in your project as you're planning it. There is staff time, your time as a student. I know you're a student, but you aren't doing this for free. If you were there in the organization, you would be receiving pay for your work. So what does it cost for you to be able to do this project? Including, you have to think about all the time you put into the project. Training costs, material costs for training. Even if you subsidize that as a student and you provide it, it's still cost that goes into that project, because I know there's many times students subsidize, they supply it themselves, the organization may not, but that's still cost that goes into the project. Any overhead costs, which are things that you might not think about, but you're taking up a room to do training. What does that cost incur? And so having somebody that can help you with that is extremely helpful. And usually there are facility people who can do that, or my go-to always is event planning or administrative assistants who are used to going and doing that work. So, well, one last point that I want to bring up is that we don't often think about productivity as a cost factor. But as a student or as a change in any change project, you are pulling people away to help explain the project, or you're educating them, or you're, having them do audits. There's costs that occur when you're pulling people away from the work. So thinking about those productivity losses would be important or productivity gains perhaps, in how you're making the process more efficient. So thinking about those would be important to the ROI of your project. So in addition to ROI, I'd like to talk about and just plant a seed for a thing called value of investment. We're talking about return on investment. Well, this is the value of the investment that you're making. And it's a non-financial benefit of the project, such as one that was very near and dear to my heart, which is culture change or culture shift, increased engagement. These are things that you can't put a box around them, but they are things that increase the value of the work that you've done. And you want to capture these. Sometimes we call them soft outcomes. I've even heard them called tangential outcomes. But you want to think about what it is that you are doing that is bringing increased value added to the organization that isn't necessarily the impact or the process or financial. So thinking about these factors, students may not consider readily about how they can enhance, or that they do enhance, patient satisfaction, patient safety, a culture of safety, that people are now talking about things differently than they did before. Those are cultural shifts. Even quality of life, of how you're influencing the quality of life of either work life or patient outcome. So thinking about those things, higher staff satisfaction, reduce turnover. Now you go, oh, that's a numerical thing. Yep, but what got you there? There are maybe some valuing things that you're adding that are soft that you may not get, that are getting you to those better numbers. So think about that. The last one I would talk about that I think we often forget is interprofessional practice. How are you enhancing team collaboration? For example, there was a student I was working with was working on huddles, and they were trying to get the huddle to be interdisciplinary, interprofessional. And as they were doing that, they had some folks in the interprofessional team that said, I don't know that that's valuable. Well, as they started working with the whole entire team, trying, doing what change management is, trying to get the processes to working to where we can get to the outcome, this person that was kind of, not liking it so much, they ended up saying in a meeting of interprofessionals, you know what, that worked really well. I really like that. I wasn't going to like it in the beginning, but I really like it now. It really gets us more efficiency. So that was really a soft outcome, if you will. It was a VOI of that project. So hopefully that helps.
Finally, if your project shows no measurable impact, how should you proceed, and what lessons can you take from the experience?
Oh boy, what a powerful question, and so important, particularly for DNP students, every student really who does any project, but people who are out there in the clinical setting who will be doing projects as well, because as we all know, people are looking for definitive improvement, right? That's what we want. Of course we do. That kind of goes without saying, right? We want to see that, but what happens when we don't? Think about VOI in a little bit of a different lens, right? What's the value added of you even doing the project? What did you learn? What can you add to the understanding? So I would say that when a student doesn't get measurable impact, the first thing to do is a lot of what Kerry was already talking about implementation planning. Go back and look at, how did I collect the data, first of all? How did I collect it at baseline? How did I collect it at the end? What happened in between? Like I said earlier, did the organization shift in the middle of your project? And so that really influenced now what you're getting for outcomes. Did your process change? Did your key players who were in your project, did they up and leave? People change jobs? Did people leave? So there's many things that can influence how that project went. What you want to understand is the value of your actual application of the project, particularly as a DNP student. So I would say that, what did you learn? How does it inform us? How can you look at planning? Use it as an introspective tool. Don't use it as a failure. In high reliability organizations and in learning organizations, failure is supposed to help us understand. It is not a negative. And so I would encourage you to reframe that and go, what did I learn from this? And what can I share? I had a student who tried to get in an organization. She didn't work there, but she tried to get in this organization the whole entire semester. She had meetings, she shared data. All of a sudden, when she shared data, she started getting questions from other folks, but she never got into the organization. And she goes, I totally failed. And I said, let's reframe. What did you learn? I learned that it's really hard to get in an organization. Yes, but why? Because of politics, because of, and how, what about data? Oh, it's almost impossible to get data. Okay, what about that? What about, did you learn about when you did get the data and you did share it with leaders, what happened? We reprocessed everything. We just evaluated. And she went, wow, I really learned a lot this semester. Go, you sure did. Because you learn what doesn't happen when it's not tied up with a bow. And what did you do? So it wasn't a failure for her, but she did not have the project that she intended to implement. She didn't get it even done. But she learned more than she would have probably ever learned. If she'd have done it, it would have been a nice tied up bow. So I would say, when you don't get a good measurable outcome, think about the VOI. Think about what you learn and the value of that information to your colleagues in particular too, not just yourself, your colleagues, because then they're in your cohort of school. They're going to go, wow, you're still thriving, even though you didn't get the nice bow. Yes, I'm still thriving and I learned a ton. And so I would encourage that. And then think about planning and implementation and what you could have done differently, if you could have done anything differently, and how you can apply that to your future project management. So those would be the things that I would say, include those in your lessons learned, so that you really are, lessons learned to me are like icing on the top of your cake. They are the things that make it juicy and good. And, you want to have lessons learned. If you just have your project explained in your report, but never a time for introspection and looking back, you're going to be missing major learning opportunities. Kerry, what would you add?
Ellen, great job covering that. I would add that they need to pull out their quality improvement tools to do a root cause analysis of everything. And you hit on some of them, were people following the processes that they put forward to carry out whatever that practice change so that you'd get the impact? Did that happen? Was the implementation plan communicated effectively? Was there? I would even go back. So I'm thinking that, when I have a student that has this happen, I go all the way back to, did you have the right clinical problem? Did you pull the right evidence? Did you critically appraise that evidence, synthesize it? Every single step needs to be gone through. If it's not easily identifiable, because some projects, I've had happen often, the leadership changes. Mm-hmm. So that's a culture thing. And now it's no longer a priority. There are other clinical problems that are a priority in that setting now. So that's really been the one I most commonly see. And so it's a great lesson to learn. And then how are you going to navigate it? And so again, I say, bring on your team, right? That's your faculty advisor, your clinical mentor, your stakeholders, because the clinical problem doesn't go away, right? I don't think a lot of these problems that they tackle. So it's just figuring out how to navigate that new leadership to address it. And again, I should say that this is beyond the point for academia. Like, they have graduated, but we want to equip them with the tools that they're going to come across this in wherever they go to practice. It's something that's common. And so just try to give them some things to navigate that.
Thanks so much for your time today, Kerry and Ellen. We look forward to part 4.
Thank you.
For more great content from the Nurse Practitioner, Be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at The Nurse Practitioner Journal and on X at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.